All right, welcome to this explainer. Today, we're tackling a fundamental truth in clinical practice. Real-world medicine, just like those high-stakes board exams you take, well, it doesn't test the obvious stuff. It tests the margins. We're going to dive into how recognizing a really subtle dividing line can literally be the difference between giving routine reassurance and catching a life-threatening crisis. Picture this high-stakes clinical scenario for a second. A 3-year-old is brought into your clinic because they just aren't meeting their speech milestones. So is this child simply a late bloomer, or are they experiencing a full-blown neurodegenerative catastrophe? It's a terrifying question, right? But it perfectly demonstrates how identifying a single, subtle tipping point can completely alter your entire management pathway. It's a call you absolutely cannot afford to get wrong. So to master these margins, here is our cognitive roadmap for today. We're breaking this explainer down into 3 critical diagnostic tipping points. 1, progression versus regression. 2, the mediastinal architecture. And 3, the 12-month milestone trap. Okay, let's dive right into this with part 1, progression versus regression. There is a stark, absolutely crucial difference between a developmental delay and a developmental regression. I want you to think of a delay as just a slow velocity of acquisition. In conditions like autism spectrum disorder or global developmental delay, the child is actually still moving forward. They're gaining skills, sure, maybe at a much slower pace than their peers, but the key here is that those skills are not lost. Developmental regression, on the other hand, that is the active loss of previously mastered milestones. This is a massive clinical red flag. It's a siren signaling a potential neurodegenerative or metabolic catastrophe. Attributing an active loss of social or language skills to a child just being a late bloomer is a fatal diagnostic error. Regression is never, ever normal. So, how do we separate the signal from the noise? Well, when you have a patient, usually a girl, who is developing totally normally until about 6 months of age and then suddenly begins to regress, you've got to be on high alert. If purposeful hand use gets replaced by stereotypic hand-wringing movements, that right there is the pathognomonic signal for Rett syndrome, which we know is tied to the MECP2 mutation. Similarly, if a child loses communication and social skills, which often presents by age 2, the correct execution is immediate screening for autism spectrum disorder, and you pair that with a formal audiology evaluation to rule out hearing impairment. But here is the critical pivot. If the regression involves motor skills instead of social skills, your target shifts immediately. You're now looking at metabolic or genetic testing. And this brilliantly illustrates what that looks like in the clinic. Take a 4-year-old boy who plays entirely by himself. Instead of socializing, he spends hours just building block towers, makes absolutely no eye contact, and throws massive temper tantrums if its strict routine is altered even a little bit. This is a classic presentation of autism spectrum disorder, which historically was known as pervasive developmental disorder. Notice the impaired social cognition and those highly restricted repetitive behaviors. Recognizing this pattern early on is huge because it allows for critical behavioral and educational interventions. All right, shifting gears entirely. Part 2, the mediastinal architecture. We're navigating into pediatric heme-onc now. Take a look at this. This is the absolute hallmark of acute leukemia. Leukemic blasts on a peripheral blood smear, an abrupt onset of bone marrow failure, which clinically looks like petechia from thrombocytopenia, fever from neutropenia, and bone pain from marrow infiltration, coupled with these circulating blasts, that is a classic presentation you just absolutely cannot miss. Now, we really need to draw a hard dividing line between 2 extremely aggressive pediatric malignancies here. Acute lymphoblastic leukemia, or ALL, is actually the most common childhood malignancy. It presents with that marrow failure we just talked about, and you'll see greater than 20% lymphoblasts. A huge point to remember is that T-cell ALL characteristically presents as a massive mediastinal mass in adolescent males, and that can physically threaten the airway. On the other side of that margin, we have Burkitt lymphoma. This one is driven by a very specific translocation, T814, involving the c-Myc gene. And this thing has an incredibly fast doubling time. On a tissue biopsy, we get that classic starry sky appearance, which is literally just macrophages eating up apoptotic debris. Clinically speaking, the endemic African type usually involves jaw lesions, while the sporadic type we see in the Americas presents with abdominal lesions, which often cause intussusception. Now, because both of these malignancies have incredibly high cellular turnover, we absolutely have to talk about tumor lysis syndrome. This is the abrupt destruction of a massive number of tumor cells, usually right after you start chemotherapy. When these cells burst, they just dump all of their intracellular contents right into the bloodstream. This causes massive hyperkalemia, hyperphosphatemia, hyperuricemia, and conversely, hypocalcemia, because all that calcium binds to the excess phosphate. The absolute dumbest mistake you could possibly make here is initiating aggressive chemotherapy without preparing for this massive metabolic dump. Now, what's really interesting about this slide is exactly why this is so incredibly dangerous for the kidneys. When those tumor cells are destroyed, purine nucleic acids are metabolized into hypoxanthine and xanthine. Those are then converted into uric acid by an enzyme called xanthine oxidase. This massive, sudden load of uric acid can literally crystallize right inside the renal tubules, and that leads straight to acute kidney injury and renal failure. So how do we prevent that? This gives us an exact step-by-step execution protocol to save your patient's kidneys and, honestly, their life. Step 1 is aggressive intravenous hydration. You have to flush the system. Step 2, and this is before you give any cancer drugs, you administer allopurinol, which blocks that xanthine oxidase we just mentioned, or resburicase, which is a recombinant uric oxidase that actually clears out the uric acid. Only then, at step 3, do you initiate the chemotherapy. Execution is everything here, folks. If you mix up this order, your patient goes into acute renal failure. Moving on to part 3, the 12-month milestone trap. Let's look at some execution gaps. Okay, you probably know the core rule of pediatric milestones. Each new skill is built on an earlier one in a highly predictable way. Kids rarely just skip a step, but there is one specific timeline where the diagnostic lines get really blurry for a lot of practitioners, and that happens right at the 12-month mark. Let's break down this cognitive trap. At 12 months, you have to distinctly separate gross motor skills from fine motor skills. A 12-month-old should be walking with one hand held or maybe standing alone. That's gross motor. But for fine motor, they need to have developed a fine pincer grasp. If they are still only using a primitive raking grasp at 1-year-old, that is a significant fine motor delay. Furthermore, their language needs to be specific. They should be saying mama or dada directly to the correct parent, alongside knowing maybe 1 to 3 actual words. So the crucial point here is strictly executing the right diagnostic workup. If an 18-month-old has totally normal motor skills but lacks a vocabulary, your very first thought must be hearing loss. You order a formal audiology evaluation immediately. What about motor? Well, if a child isn't walking by 15 months, actually, that's still within normal limits. But if they aren't walking by 18 months, that mandates an immediate workup for muscular dystrophy, so you check that creatine kinase, or cerebral palsy. Oh, and if you ever notice a definite hand preference before 1 year of age, please don't celebrate that the baby is right-handed. That is a massive red flag for upper motor neuron pathology. We've covered a lot of ground today, and we've seen that whether it's distinguishing a slow developmental delay from a catastrophic regression, anticipating a tumor lysis metabolic dump before starting chemo, or separating those gross from fine motor milestones at 12 months, the details matter immensely. The obvious things are easy. It's the margins that define true clinical expertise. So I'll leave you with this to think about. If clinical medicine is truly decided on the margins, which subtle dividing line will you miss tomorrow? Keep your audits strict and always trust the signals. Thanks for joining me on this explainer.